Hey guys, just a reminder, this is not official medical advice or such. Please seek an appointment with a licensed medical provider. Welcome back, everybody, to another episode of Explain This. I'm with the star of the show, Robin Riddle. Robin, how are you?
Doing great. How are you?
Yeah, I'm doing wonderful. How is it over there in the West Knoxville office? Y'all doing okay today?
Doing good. It's a rainy day over here.
It's rainy. I don't know about you, but I'm kind of like excited about the rain. It's like after these hot months,
Yeah.
it's kind of nice.
I'm not hating it. It's okay.
So today's topic isn't one of our more fun episodes. It's about recurrent pregnancy loss, and it's something that I know that you've dealt with patients in your functional fertility practice. Let's talk a little bit about it. Let's explain it.
Okay. So as you said, with my functional fertility, I unfortunately do see this sometimes, and I feel like the care surrounding recurrent pregnancy loss is not great. The help that patients are getting, just like the help that patients get for general infertility, is not great. So I want to give some more information, some more options for things people can be looking at. So just to start in general, a miscarriage is defined as a loss of pregnancy prior to 24 weeks gestation. After 24 weeks, the terminology changes. It's called a stillbirth after that point. Some other terms that patients may hear is a chemical pregnancy. So this is a loss of a pregnancy prior to 5 weeks gestation. And then another word that's used often that I really don't like, but is the true medical terminology, is a spontaneous abortion. This is just another word for a miscarriage. But some patients, when they hear this, that they just hear the word abortion in with it at all, definitely off-putting. This just means that the body has spontaneously aborted the pregnancy. So current statistics show that the rate of miscarriage is as high as 1 in 4 pregnancies. So about 25% of clinically recognized pregnancies will end in a miscarriage, which is insanely high.
Yeah.
But the good news is that most of those patients can go on to have a normal, healthy pregnancy with their next conception. So statistically, about 76% of those women who have had one miscarriage will go on to have a very normal, healthy pregnancy and not have any issues with the next one. If patients were to experience a second miscarriage in a row, the statistics for success start to drop a little bit. So after 2 miscarriages, about 70% likelihood of a healthy third pregnancy, and so on like that. Recurrent pregnancy loss is now defined as 2 or more consecutive pregnancy losses. Used to be 3. So previously patients had to go through 3 miscarriages back to back before insurance warranted doing a workup, which I think is insane. So thankfully they've dropped it down to 2 or more miscarriages. But for me, from a functional medicine standpoint, I'm happy to offer patients a workup after even 1 miscarriage, because even 1 lost pregnancy is too much.
Oh, it's absolutely brutal. I know friends who have gone through it.
Yeah.
And is there like a time frame that the 2 need to be, like the 2 consecutive, or is it just 2 in general?
2 in a row. So they could be 2
Okay.
years apart, but it has to be back to back to be considered recurrent. So if you have a miscarriage, a successful pregnancy, and then another miscarriage, technically from like an insurance standpoint, they don't consider that to be recurrent.
Okay, I'm with you.
So standard workup for a patient who's been classified as having recurrent pregnancy loss is most of their OBGYNs are going to screen for any kind of clotting disorders. So things like factor V Leiden, antiphospholipid antibody syndrome. They're going to look for genetic issues. And when they're looking for genetics, they're looking at just generalized testing on mom and dad to see if either a parent carries a genetic issue that would predispose to miscarriages. They'll assess uterine anatomy. So if something's off with the uterus, like if it's shaped weird, if there's like a septum in the uterus, endometriosis, things like that, that are actual anatomical issues, they'll look for that. And they're going to look at generalized hormone levels. It's all useful information. It's all stuff that absolutely needs to be done. But it doesn't give us the whole picture, and a lot of times patients come out of that workup with absolutely no answers. It's just, well, poor luck, I guess. But truly in about at least 60% of cases, we should be able to find the cause for the losses. And a lot of times it is something that we can help.
Is to find the cause, is that pretty immediate after doing this workup, or could it take a little bit of time of kind of digging in from a functional perspective?
It could take time. So if it's not one of the easy, like very baseline things that come up, we may have to dig a lot deeper. So it could absolutely take some time of digging down into this to figure out truly what's going on. And it's just a process of elimination. If it wasn't the things that we've already checked, we go down the list into the other things that it could be.
It's almost like an elimination diet, not to make light of it, but just, you start with one and then you go to the next thing and to the next thing.
Yeah, take away each factor that wasn't the issue until you find something that could have been the issue.
So what does a functional fertility outlook on something like this comprise of?
Yeah, so there's a lot of factors that we look at in trying to find the why. And I mean, that's the whole thing with functional medicine, functional fertility is looking for the why. So I still want my patients to have that standard workup done. They can have that done with their OB. All the blood work I can do. We just can't do like the anatomical stuff. So we're not doing the ultrasounds and all that kind of stuff within that workup. But we're still looking for the anatomical issues, clotting disorders, the antiphospholipid antibody syndrome, all that kind of stuff. Once standard workup is done and we're not finding anything that way, other things that we start looking into, one of the big things is autoimmune issues. So in the standard workup, they look for very abbreviated autoimmune things. But one of the things that's missed so often is looking at an ANA, antinuclear antibodies, looking to see if there is another autoimmune disorder. I have so many patients that have come to me with infertility or recurrent miscarriages that no one's ever drawn an ANA on them. And a lot of them have come back really high. And so that tells me that their body is attacking healthy cells for some reason. And it could be deciding to attack the healthy cells of the baby instead of the mom's healthy cells at that time. So an ANA is a critical first step in looking for reasons behind recurrent miscarriages. And there's a lot of research coming out about using LDN in pregnancy. And if anybody's listened to any of our other videos, we talk about LDN all the time. I absolutely love LDN. There's this fabulous doctor, Dr. Boyle, that has kind of spearheaded the research into LDN in pregnancy and showing absolutely fantastic results. So in these patients who have these autoimmune issues, they can actually just be started on LDN and stay on it through a pregnancy and have great, healthy outcomes. So that's a huge one.
That's interesting, Robin, because we did our Q&A show last night, and I was with Andy, and he said that in the show a fertility came up in LDN, and Andy mentioned that you had mentioned to him that LDN is really working great for this. Yeah,
it really is. There's not as much big studies, not as many big studies in it as I would like, but all the studies, all the statistics that are coming out of it look very, very promising. So I love it. I'm very comfortable with LDN, and I do have several people that I have started on for their autoimmune issues and trying to help them get pregnant.
Super cool.
So another thing we look at is metabolic disorders, insulin resistance, diabetes, either full-blown type 2 or pre-diabetes, obviously could be huge issues. So I think I've shared before, statistically, a A1C of 5.6, which is not even pre-diabetic. It's still technically within normal. But an A1C of 5.6 reduces the likelihood of achieving a healthy pregnancy by about 50% when patients are doing IVF. So I know that's a statistic very specific to IVF, but that shows you if it can make IVF fail, then it could also have an effect on a natural conception. So definitely if we have insulin resistance, diabetes, prediabetes, this can have a huge effect on a growing pregnancy, can be a cause for miscarriage. Hypothyroidism that's not treated appropriately. So even like a subclinical hypothyroidism where TSH is just above optimal, not above normal, can be a contributing factor as well. For pregnancy, we really like to see that TSH less than 2. So above 0.5, but less than 2. So even a TSH of 3.5 could cause miscarriages. And then, of course, autoimmune thyroiditis, which is Hashimoto's. So if patients have those antibodies with their thyroid issues, that can be another cause as well. And all of these are things that we can help. These are not things that we just find the answer and say, well, this is why, like, so sorry. These are things that we can do something about.
No, I love this, Robin. It seems, often when you hear about miscarriages, the tone is often like a hopelessness. It's like a feeling of not having control, and all these things, like you said, are stuff that you can do.
Yeah.
And that's what I love about your approach to fertility. So I apologize for interrupting,
No.
but I just had to get that in there.
Yeah, absolutely. I mean, I really love to empower parents, empower these women that are going through this, that we don't just have to sit back and accept the answer of like, sorry, you just can't keep a pregnancy. We can dig until we figure out why.
Yeah.
So another big one that's very often missed is infections. Because a lot of people think if I don't have symptoms, I don't have an infection. But we can actually have what's called stealth infections that can hide in the body. And they can cause issues. They can cause inflammation. They can cause, of course, miscarriages. You can even have like preterm deliveries. You can have preeclampsia in pregnancy, like complicated pregnancies, all because of underlying infections. So looking into this is super important. When I'm taking a history on patients, I'm asking about any history of any type of pelvic infections, pelvic inflammatory disorder, any history of STDs. I actually get a history of sexual partners and if they've used protection or not, because the number of partners without protection increases the likelihood of having an underlying infection. Any sort of recurrent yeast infections, recurrent bacterial infections, recurrent UTIs, all of those are signs that we need to be looking deeper to see if there's a stealth infection that's hiding there. One infection in particular that can cause major issues is called ureaplasma. It's in the mycoplasma family. This can be present without symptoms. It can move into the cervix, the uterus, into the fallopian tubes, out into the ovaries. It can be in the male or the female partner. It can cause issues in both. So there have been studies that have shown that anywhere between 80 to 90% of couples who are dealing with infertility have this infection. They have ureaplasma in their body.
Interesting.
So huge cause for infertility, huge cause for miscarriages. It's been established, again, that it can cause early pregnancy losses, preterm deliveries. Like, it's a really big deal. And it's a really easy one to test for. That's what drives me crazy.
I was going to ask you, Robin, are these blood tests? This is super naive. How do we test for these?
So urine or swabs. So like the ureaplasma specifically for the male partner, it's going to be a urine sample. For the female, it's just a endocervical swab. So this is just like getting like a pap smear when you go to the doctor. Like, it's the same type of swab. Women can go to their doctors and ask for this test. I have found that some OBGYNs are not big proponents of doing this test. Not really positive why. I've actually had them tell patients previously that it's a very difficult test to do, or that it's not a very accurate test, or that it doesn't have an effect, like it doesn't mean anything. All of which are not the case. And so I've had to really tell people, like, we need to find another doctor, or you need to really advocate for yourself and tell them, I don't care, I want the swab done. Because I have had several people that come up positive for this. So it's actually very easy to look for, and it is very easy to treat. It's 2 back-to-back rounds of antibiotics given to both partners. Don't love antibiotics, but this is a situation where I definitely recommend them, because if we have ureaplasma present that's causing infertility or causing miscarriages, we need to get rid of it.
Well, it's just interesting, Robin, how like so much of this is around finding that problem, and then, like you said, it's quasi easy to treat once you nail it to what's actually happening.
You just gotta know where to look to find the why.
Yeah.
MTHFR. So we've talked a lot about MTHFR. I actually have a video on this, but MTHFR testing is another thing that I recommend. Or we look at the downstream, which is going to be homocysteine and B12 levels. So high homocysteine levels is something that can cause a lot of inflammation, which can lead to miscarriage. Low B12 levels has also been linked to increased rates of recurrent pregnancy loss. Again, very easy things to look for. A lot of my patients that I'm seeing for functional fertility, I'm already starting them on basically the treatment for this, which would be folate, not folic acid, and a methylated B12. So
Okay.
the prenatals that I recommend have high doses of folate, high doses of methylated B12. So a lot of times I'm already ruling this one out, but if it's a patient coming to me who has not seen me previously and has been taking things like folic acid or cyanocobalamin, this could be an issue there.
Okay.
Of course, we're looking at lifestyle. This is absolutely a factor. So people who smoke, illicit drug use, extremely high caffeine intake, high alcohol intake, chemical or toxin exposure. So people who have jobs where they're around a lot of toxic elements, all of those things could be contributing to miscarriage. And then again, anatomically, I had mentioned endometriosis. It's less common to make it this far into life where you're actually having pregnancies and not know that you have endometriosis, but I've seen it. Some people don't have a ton of symptoms of it. So just assessing for any signs of endometriosis, like really heavy periods, really bad cramping, really bad bloating before cycles, abdominal pain, things like that. Assessing for any risks for endometriosis. If there's anything there that points me to that, but the patient has not had that diagnosis yet, I do have a doctor here in Knoxville that I love that I refer out to for further evaluation.
That's super. I mean, guys, we'll link in the description below some of the videos that Robin has already done on some of these things that could be causing the miscarriages. I'm seeing here in my notes, Robin, that the stage of when we find this matters.
Absolutely.
Can you talk about that?
Yeah. So whenever we're going through a pregnancy loss workup, one of the first questions that I'm asking is, when did it happen? Because where you were in the pregnancy can actually give me a lot of clues as to the most common causes for loss at that point. Okay. So you have the pre-embryonic stage, which is going to be from conception to 4 weeks. So this is like you've just barely gotten a positive pregnancy test at this point. So in the pre-embryonic, most common cause is going to be genetic issues with the embryo or implantation problems. So like a really thin uterine lining, a clotting disorder, or low progesterone are the most common pre-embryonic.
Okay.
Embryonic kind of overlaps here. So the embryonic stage is going to be 5 weeks to 9 weeks. Most common causes are very similar to the pre-embryonic, so genetic factors still being a really big one here, low progesterone. At this point, we also start considering oxidative stress, and so damage to the embryo from free radicals in the body. And then we have the fetal stage. So fetal stage is going to be from 10 weeks on, so 10 weeks up to 24 weeks. Most common cause at this point are going to be clotting disorders, anatomical issues with like uterine abnormalities, or autoimmune factors, like the body has attacked the baby for some reason.
10 to 24.
Yep.
Okay.
And so then just a couple of other points on this in general. I have said previously genetic issues. We talked about that a lot. When a standard OB workup is going on and they're looking for genetics, they're just measuring, like looking at the blood of mom and dad. Do you both carry the same weird gene that could line up to be something bad, basically? One of the things that a lot of them don't think about is actually looking at the genetic quality of the eggs and the sperm. Harder to measure in eggs, but it is something that we can help to improve in eggs. But in sperm, we can actually measure the quality of the genes, the quality of the DNA that these sperm are carrying. We've done a video about this before, the DNA fragmentation index. So once sperm have been created, they are unable to fix themselves.
Okay.
So women are born with your eggs. Eggs can be repaired. We can actually make them a little bit better. We can repair the DNA within eggs. Sperm, once they're made, they're stuck at what they are. They can't fix themselves. So, yeah.
Robin, would that be so again, this is probably super naive. That's in the embryonic stage, right?
Yes. So like the repair that can happen.
Yeah, for the sperm DNA fragmentation.
Oh, so looking at sperm DNA fragmentation is actually the analysis that we do. So it's actually a different type of semen analysis that we look at.
Okay.
So we're actually collecting a semen sample and we are looking at the sperm and actually looking at the DNA that's contained within the head of the sperm to see if that DNA is broken.
Got it.
And so, like I said, that's a genetic issue that they don't, or a genetic factor that they don't really think about. But if you have damaged sperm, damaged DNA going into this embryo, then obviously the embryo could have damaged DNA that might not be compatible with life. So at conception, so egg meets sperm, at conception, mom's DNA in the egg can fix the DNA of the sperm to a certain extent. So as always, women are kind of cleaning everything up, fixing guys' messes. We can go in and kind of fix whatever mess has been made of that sperm to an extent. But there is an extent, if the DNA is damaged too badly, it cannot be fixed. And so that's when you create an embryo that has like trisomies or deletions or something like that, that's not going to be a compatible embryo, and so the body will spontaneously abort those often.
Okay.
Especially in younger women.
Okay.
The body is more likely to hold on to something like that as you get older, which is why we have higher rates of like trisomies with older women. So all of that to say, when we're looking at genetics, we can't ignore the genetics that are found in the sperm. DNA fragmentation index is absolutely a test that I recommend for patients who have recurrent miscarriages, for patients who have had like repeated IVF failures, or who have done IVF and have really low quality embryos, like if they're coming out genetically not great or just a low quality. Looking at the DNA of the sperm is a really big step in the process.
Yeah, and I would encourage everybody to watch that video because, again, there's a lot of hope that comes with that test, and there's things that you can do from a male standpoint. So I would encourage anybody who's kind of going through this to watch that video on sperm DNA fragmentation.
Absolutely. And then I mentioned earlier that standard OBGYN workup will look at hormones. I approach hormones a little bit differently. So I will look at them as well. If we have had a miscarriage and we are after the fact trying to figure out what happened, we do timed, like cycle day timed labs for hormones. So I'm looking typically about a week post ovulation, which is around cycle day 19 to 21. I'm looking to see what progesterone levels specifically are looking like at that time. I know that if we have low progesterone not in a pregnancy, that obviously it's going to be more likely that when you do conceive again, we're going to have low progesterone. So I like to look at this in my newly pregnant patients as well to try to avoid having miscarriages to begin with. So anytime that I have patients that conceive, I have them call me as soon as they have a positive pregnancy test. We start doing serial HCG and progesterone levels. If progesterone levels are low starting out, then I'm going to start them on some daily progesterone. If progesterone and HCG are low and we're not seeing the HCG go up, that can give us a sign that that embryo might not actually be viable. So the plan would change at that point. But yeah, so I actually look at progesterone early on in pregnancy. A lot of OBGYNs don't monitor progesterone unless you've had several miscarriages. I look at it in everybody to try to avoid those miscarriages.
Because you want your progesterone level to be high.
Yes, progesterone is like pro-gestation. It is what maintains a pregnancy. So we really need a progesterone level, ideally over 15 is where we want to be. And then that should start to rise in early pregnancy. So if I have someone whose initial progesterone level comes back at 5 or at 7, then I know that they're a higher risk for a miscarriage. I'm going to start them on progesterone early on.
Got it.
And if we've established that that patient has a known progesterone issue, sometimes I'll even start them before we even know if they're pregnant. So in that luteal phase, we'll go ahead and just start cycling on progesterone so that if there is conception, we've already got the progesterone on board to help maintain that pregnancy. Okay.
Interesting.
And then there's other kind of odd, less common reasons for pregnancy losses, like food allergies, celiac disease, high like heavy metal levels. There can be some other kind of random things that can be causes, and always are things that are kind of on my list of things that I'm thinking of, but just not the top of the list of the most common things that we see.
You know, Robin, this has been really great just to see kind of the way you're thinking about approaching visits like this. And, you know, one thing I will say is like, there's things you can do. And I know this is a very frustrating topic. If you're watching this, you know, maybe you're going through it at this time. Robin, is there any like message that you can send those people that might be going through it right now? I know you're dealing with it every day in office.
Yeah. Well, the big takeaway is 1 miscarriage or 2 miscarriages does not mean that you're never going to have a healthy baby. It's very sad to go through, but there is hope. Like you said, there is the possibility for answers. So if you're going through this and your doctor is not giving you answers, or your doctor is not digging deeper for the why behind it, then there's other things that we can be looking at.
Robin Riddle, thank you so much.
Absolutely.
We'll see you next time.
Don't go away.